Bon dia, si us sembla, comencem. A mi em fa especial il·lusió. Avui us presento jo la sessió tècnica que tenim avui aquí amb tots nosaltres, perquè realment crec que és un gran repte aquest que ens hem posat per abordar avui com el possiblement d'un futur pròxim, encara que possiblement ja el tenim aquí. L'envelliment ja ha arribat i el que ens arribi posteriorment serà un tsunami, no? Segurament la sostenibilitat financera, no? Que és del que parlarem avui, en un sistema sanitari amb una població que s'envelleix a Espanya i a tota Europa. La realitat és que parlareu de l'evidència sobre la projecció financera a Europa i la relació amb la despesa sanitària. Us centrareu a Espanya sobre les implicacions de l'envelliment en el finançament del nostre sistema sanitari i, finalment, abordareu diferents polítiques, si ajuden o no a mantenir aquesta accessibilitat accessible. Jo només us presento la Maria Lluïsa, encara que segur que tots la coneixeu, i ella ja presentarà els ponents, que crec que és el que toca. La Maria Lluïsa és una professional metgessa, especialista en Medicina Preventiva i Salut Pública, doctora en Medicina i màster en Planificació, Finançament i Polítiques de Salut, que té una gran trajectòria investigadora i de salut pública, que treballa al Consorci fa molts anys, que ens ajuda i ens fa una feina de seguir treballant en polítiques de salut i en avaluació, que no avaluem gaire i és una cosa important, avaluar, i col·laborant en el màster de salut pública i amb línies d'investigació del grup Gaia, que és un agaur, que són línies potents. Gràcies, Maria Lluïsa, per tota la feina, a part de per la que faràs avui, que és moderar aquesta taula superinteressant. Jo us tindré que deixar, però endavant i que sigui molt aprofitosa la jornada. Gràcies a vosaltres.
Thank you very much, Cristina. I will carry on in English so that my guests can understand everything. Today we have here a very interesting... you don't... Sí. Pero el micro no es para la sala. El micro es para la gente que está conectada online. No sé, és de cridar més, no? Because we don't have micros in the room, you understand that. You have to speak up. Sarah, you too. I am very thankful to the WHO Barcelona office and to the team here with us. I'm very happy that you really could make it and to have you with us. So, and especially as Cristina was saying, you are addressing a real challenge of our health system for the next years. We know that the population in Europe is getting old. We are getting old, all of us, particularly me in this table. And we have to make sure that the access to healthcare is affordable for the population in equitable conditions. So the question that the team would like to answer today is how to address health system financial sustainability and affordable access to healthcare. To do that, our speakers are going to address three themes that Cristina just said. First, how can Europe sustain affordable access to healthcare? Then, if not, what is going to happen with our population? And then to think and to analyze what policies do help or not to ensure access to healthcare. So I will start by presenting our first. They are going to speak in order, so I will introduce you one by one according to your presentation. So now I start with Tamas. Tamas is Evetovic. Is good? Good pronunciation in Hungarian. I have been practicing all the week. Tamas is the head of the WHO Barcelona office for health system financing, which is the office leading the technical assistance to the European countries. And he's going to discuss, to share the information on financial protection in Europe and how it looks with the priority of health. So when the floor is yours, Tamas, Sarah and John, you do as you like, if you want to go in front of us or to stay with us. You have another one, yeah? I'm sorry. Sorry. Yes.
Yes, thank you very much, Maria Luisa. It's really a great pleasure to be back. I think it's now the third or fourth time, but we are coming back relatively frequently. And thank you very much to all of you for hosting the WHO Barcelona office here in Barcelona, or for hosting the WHO office here in Barcelona. It's really a great privilege to be here, even in a very hot summer day today. But the sun is shining here, as always. I was referring to this city that even when there is a bit of rain, there will be sunshine coming in a few minutes, and that's very exceptional. So this office, as many of you know, works on health financing in general. But in particular, we focus a lot on monitoring financial protection, affordable access to healthcare, whether people have access to healthcare, how much they have to pay out of their pocket at the time of using services, and whether this leads to financial hardship or not. And we are very proud of this work. For the past 10 years, we've been researching this. Sarah is leading this work in the team. And the reason why we are proud of this is because most of the evidence that I'm going to briefly present was practically non-existent 10 years ago, definitely not available for so many countries that we have in the European region. In WHO, it means 53 countries for the whole region, and we have now data for 45 countries. And this looks at measuring financial hardship, whether people have to pay so much out of their pocket that it has impact on their ability to pay for other goods and services, especially those essential basic needs like food, housing, and to pay the bills, electricity, and so on. And we have presented some of the data already here. Now I'm going to show you just quickly on 4 slides the latest information that we have, all of which are available on the internet. You just have to type in UHC Watch, and all our data, analysis, and publications are available online. And they are updated quite frequently, twice a year or even more times, depending on which part of the data we are updating. It's not just numbers, but it's also qualitative assessment of how countries perform, including Spain. And we have a very detailed report on Spain. So this first chart shows the incidence of impoverishing out-of-pocket payments across the European Union and UK. Less than 1% in Slovenia. Maybe some of you are surprised. Slovenia is the best performer. Spain is also a quite good performer, but it goes all the way up to 8% in Bulgaria, which means that 8% of the population faces impoverishing level of health expenditure, meaning that before spending, they either drop below the poverty line, or if they were already below the poverty line, which is an internationally comparable poverty line that we use, then that's the red part of these charts. They go even further below. And the reason why we are so proud of this work is because we developed a new methodology for monitoring financial protection here in Barcelona. And over the past 10 years, this has been used by, the numbers and the evidence we produce, used by OECD, the European Union. And as of last year, this is the approach that is being used globally as well. By the World Bank and WHO headquarters in Geneva. So again, thank you very much for having us here in Barcelona, because without you, this would have not been possible. The other indicator, this was the impoverishing indicator. The other indicator is the catastrophic health spending. As you can see here, the numbers are higher, starting at below 2% in Ireland, UK, Slovenia, Sweden. France is hitting already the 2% line, Spain close to 3%. But again, Bulgaria and at the other end of the spectrum, almost 20% of the population facing catastrophic level of out-of-pocket expenditure. We are not going into the details of the methodology. If you're interested, look it up on UHC Watch, or during the discussion, we can go into this. But what I would like to show is the disaggregation. Here on this chart, the lighter blue numbers, bars are the same as before. The scale is different. And the dark blue bars show the incidence within the poorest quintile, the poorest 20% of the population. And then some of the countries, you can see that it goes up to even more than 50% of the poorest 20% of the population. So the message of this is that, of course, this indicator shows that it's the poor people who are suffering most from financial hardship, which, of course, you would say, well, no surprise here. This is what we would expect. Except that if you look at the old methodology, that was not so obvious in how financial protection has been monitored before we developed this new approach. And this is the last of the four slides, which for some of you you may be familiar with. This brings together the out-of-pocket payments as a share of the total current spending in countries and the catastrophic incidents, on the two axes. And we colored the different countries with those acronyms as well, according to their incidence of catastrophic expenditure. As you can see on the left, there are some of these good performer green ones below 2% catastrophic incidence. And as we go to the right, we see more and more and upward, more and more of the orange and red and the very dark red Bulgaria. We use here a 5-color scheme, and the explanation is there for more than 15% catastrophic incidence, and that's the darkest red. But the message of this slide is that there is a pretty strong correlation between the share of out-of-pocket expenditure in any country as a share of the total and the incidence of catastrophic expenditure for households. But there is a strong correlation, but there is still a lot of variation, especially in the middle. And the reason why we have these 15% threshold and 30% threshold vertical lines there is that as long as a country can manage to keep out-of-pocket expenditure less than 15% of total spending, their catastrophic incidence, their financial protection is quite good, catastrophic incidence being low. And there is not much variation. Some of them are above the 2% threshold, so that they are yellow, but still not much variation. When you see in between 15% and 30%, there is quite a lot of variation, although the numbers are going quite steeply upward, showing that once it's more than 15%, catastrophic incidence is increasing, but there is quite a lot of variation. And this is why Sarah will cover a lot of the protective mechanisms. So it's not only how much we spend publicly, but also how good we are protecting those who need protection the most. And that's the policy space practically for any governments to consider how to improve financial protection, especially if they don't have more funds publicly available. Because by spending more publicly, that is likely to improve financial protection, not necessarily, but that's one of the most important factors in this. And then above 30%, we just say that, look, that is really unsustainable from a financial protections perspective. You may say that, oh, there are those two outliers, Malta and Cyprus. Cyprus is definitely an outlier on this chart, but recent years, Cyprus has increased public spending extensively, and the out-of-pocket share went down from the 45% now close to 20%. So practically on the most recent slide that we would produce with data, if we had catastrophic incidents for Cyprus available, then Cyprus would be in the middle and performing quite well. On this chart, the catastrophic incidents number and the out-of-pocket share of overall spending are from the same year, and from Cyprus we have only very old data, and that's why it's an outlier. But I think what matters really on this chart is to look at those red-colored and especially Bulgaria. We would argue that for those countries that are red-colored, more public spending is essential to improve financial protection. In addition, of course, better coverage policies are needed. But without more public spending, it's really hard to make an improvement. So the next set of slides, just another four, are new slides. So this is new. For the first time I'm presenting this. And here you can see on the horizontal, the public spending on health as a share of GDP. And the vertical is the out-of-pocket expenditure as a share of current spending. So what was previously horizontal, now it's vertical. And that's why you see the 15 and 30% thresholds or lines there. And for the public spending on health as a share of GDP, the 5 and 9% are absolutely arbitrarily chosen, although I do have a story for it. As long as it's less than 5% public spending as a share of GDP, practically all the countries are red or doing quite poorly on financial protection. Again, in between 5 and 9, in the middle, that's where the variation is quite high. And above 9%, you can see only good performers. So that's how I just artificially came up with this, or maybe a bit based on some data here, that if it's less than 5, then you're in a bad shape. If it's more than 9, then you're likely to be in a good shape. Now, I'm not going to suggest that they can cut, but if they have to cut, they probably not going to suffer as much as those in the middle. And those in the middle need to be carefully considering the coverage policies and whether any cuts in health spending will lead to worse financial protection. And the reason why I'm raising this is because these days, spending goes to defense and all sorts of other areas, but not necessarily to health. And the question we face in our country work is, okay, how are we going to manage? And we need to provide some guidance. And my first guidance to those countries that we circled with red, you cannot afford to cut. Because if you cut health spending, public spending on health, then your current performance is going to get even worse. And the current performance is a very poor performance. In the middle, those countries, probably they should not cut whatsoever. But if it comes, they need to also very carefully consider the coverage policies. So maintain protection for those who need them most. And the last part, those countries, we would still argue don't cut health, but honestly, if they cut health carefully meaning cutting back on low-value care, cutting back on some services for which there may be no simple alternative private utilization which would increase out-of-pocket expenditure, or cutting back without increasing out-of-pocket expenditure, without increasing co-payments, that may not lead to worse financial protection. And the reason why I need to also come up with a few countries which are better positioned when it comes to negotiation is because if we just argue the usual way, WHO is arguing for more, that's not necessarily acceptable when it comes to talking to finance ministries and OECD colleagues and so on and so on. But I think the key message is that if you're not in the green countries, don't even think about it, because that's not the area to be cut. And again, I mean, this shows that cutting is actually, I mean, the public spending on health as a share of GDP is an important proxy indicator. But let me also show another proxy indicator to whether your spending is sufficient enough, which is the public spending on health as a share of government spending. So now on the horizontal is what we call priority to health. So within the total government spending, what share of the pie goes to health? And we argue that it should never be less than 12%. Of course, it's, again, not necessarily something scientifically proven. But as you can see here, if it's less than 12%, those are likely to be not very well-performing countries, except for Luxembourg being an outlier. If, again, to have something in the middle, I set the threshold, the other threshold at 18%, because above 18%, all countries are doing well. So, and some countries, of course, spend more than 18% of the total government spending. So it's high priority within their government spending. And again, the red ones should never ever think about cutting back on the priority to health. Those in the middle, they are not performing better, but should be carefully listening to Sarah. And then those few may cut back on priority to health as long as they can manage to keep their expenditure on the vertical below 15%, which is our proxy number. Keep it below 15% as a share of current spending, the out-of-pocket expenditure on health. And the next one is showing the public spending on health as a share of GDP and the GDP per capita. The reason why I'm using this slide is because this shows that at any country's economic level of economic development, you can see whether they are spending below or above the trend line. So when countries are comparing themselves, they prefer to compare with others who are at similar level of economic development, because we know that the richer you are, the more you spend and you can spend. And those which are red and orange colored are likely to be under the trend line, and the green and yellow ones tend to be above the trend line. So, but most importantly, again, the vertical comparison here is the relevant message. So for example, Latvia, Hungary, Romania, those three red ones are all below the trend line. So at their level of economic development, they could spend more on health. So when they argue that, sorry, we cannot spend more, that's just simply not true. That's why this chart may be useful for that argument. And lastly, just to link it not only to financial protection, but avoidable mortality, this chart shows avoidable mortality on the vertical and public spending on health as a share of GDP on the horizontal. And again, there is a link between the two. Those countries which spend less and less than 5-6% of GDP are likely to be the ones that are that have very high level of avoidable mortality. And because now we have these colored dots, this is actually a three-dimensional chart showing also that financial protection is also very weak. So these were the slides that I wanted to start with because I think it's important to see where the different countries are and what will happen with us, because I'm also increasingly interested in, what will happen with us in an aging population and society, and whether we are going to be taken care of as users of both health and social services. But first, let's discuss more about what happens to health in a population aging, in an aging society. Thank you very much.
Thank you very much. Thank you, Tamas. I think we carry on with the presentation and we let the debate for the end of it. So now I ask John to join us. Well, if you want to talk standing, it's up to you, no? As you like. So we have now the situation. How are we spending our money and how would we perform? Now, John is going to answer the question and what would happen if we can't afford to pay for healthcare. John Silus is a senior health economist and head of the London hub of the European Observatory on Health System and Policies. He conducts research on health economics, health financing, and health system performance, and also on the economics of aging population. And he has a wide experience, although he is very young, in a range of countries and multilateral organizations such as OECD, EC, and WHO. John, the floor is yours.
Great. So thank you very much. Oh, yeah. Push the button. Thank you very much. Yes, so I'm going to try and make this link between population aging and health financing to understand what the implications are of different policy choices as the population ages. And so these are, I wrote that these are objectives. I think these are also really the main takeaways that I think should come out of this presentation. So the first is to really understand why the way that you raise money for healthcare matters, not only as the population ages, but especially as the population ages. And the argument or the takeaway message will be that relying on the labor market to finance the health system, so social contributions, which are very commonly an important part of health financing, especially in social health insurance systems, that this is particularly susceptible to aging. And I think in many ways it's very obvious, because as the working age population, the size of the working age population declines, obviously your revenue base also shrinks. But this is nice to show it, I think, a bit more empirically. And then to make the link between financial sustainability and financial protection. So why do we care about the sustainability of the health system? Obviously, we care about it, as Tamas showed, because it has impacts on things like avoidable mortality, so deaths that should not happen in the presence of timely and quality care. But also it has implications for financial protection, because as we'll see, if you don't raise enough money for healthcare and people continue to use healthcare, someone has to pay for it, and it will most likely be people paying out of pocket. And so we're going to look at see what the implications are. So making this link between population aging, financial sustainability, and financial protection. So I think any presentation about aging needs a picture that goes up to show that the population is aging. So this comes from the UN population data. This is the share of the population globally over age 65 from 1950 until the end of the century. And you can see, obviously, it increases with more uncertainty towards the end of the projection period. What I think is interesting is if you think now, there's about 7 to 8% of the population globally that's over age 65. And this is going to increase to around 20 to 25% of the population. And you might think that a lot of that aging will happen in countries like Spain, and it will. But most of this, at a global level, most of this aging is happening in developing countries. So it's a lot of, because that's where a lot of the population is. It's China, it's India, it's more these developing countries that will see the biggest contribution to this change. And if we look at Spain, so this is the same data, just looking at Spain, broken up into 4 age groups. So the darker color at the bottom is children. The middle blue color is working age population. And the 2 top colors, the lighter colors, are over 65 and over 85 plus. And so I think that the Spain data look a lot like the rest of Europe, to be honest, that you see the overall size of the population shrinking over the rest of the century, a sizable decline in the size of the working age population. So here from about 61% in 2024 to under 50% already by 2060. And a big increase in especially the 85 plus population. So from 3% to 13%. And this is pretty much the story that you see across most of Europe. So you could ask, well, why does this matter for health financing? And I think first, before we talk about it, I would argue that it's not necessarily the case that it has to matter for health financing. Part of the story depends on how well people age. If we look at data, this is data from Eurostat on healthy life years at age 65 as a percent of life expectancy at age 65. We can get a sense of what people's care needs might be in the future. And I like healthy life years as an indicator because it's based on activity limitations, which is a really good metric for predicting people's care needs in the future. And so I've sorted this from the biggest improvement on the left, so Estonia, Austria, Finland, to the biggest decline on the right, which is hidden by, I think it's probably Romania on the far right. Yeah. And so you can see Spain has a slight decline. In 2005, the average person spent about half of their remaining life after age 65 without activity limitations, and this has fallen slightly over time. So if that continues, you would imagine that people have more care needs, more expensive. But okay, so to understand this question of will population make health financing unsustainable, I think to set the scene, it's useful, like Tamas, to look at some cross-country data. So to look at what countries spend now, to look at a few countries, how spending varies by age, and then to look at how countries raise revenues for health. And then we'll get to this question of, well, what happens if there are financing gaps in the future? So this is health accounts data. This is the same as Tamas, public spending as a share of GDP. The most recent data are for 2023. You can see that Spain, I think it's about 6.5%. Of GDP spent on health from public sources, slightly above the EU. If we looked at this like Tamas did as a share of government budgets, it looks kind of the same. I think Spain is around 15% of government budget is spent on health, but the order of the countries largely doesn't change. The big one that changes actually, like in your slides, is Ireland, but that's just because a lot of Ireland's GDP is the multinational corporations that no one ever sees the actual money. So the GDP is inflated, whereas the government, they don't tax that as much. So the government is much smaller. If we look at health spending by age, so this is looking for males and females, only at 5 countries. So Italy, Slovenia, so Italy is green. Slovenia is, I don't even know what color that is, blue, black, gray, something, one of those colors. Spain is purple, Slovakia is yellow, Bulgaria is red. And I picked these 5 countries, and you'll see they will reappear in the next few slides because they're very different ways of financing their health systems. But I think in all of these countries, even in Bulgaria, which spends the least, you see the spending patterns by age that you would probably expect. So at very young ages, you see it's more expensive, babies, very expensive. And then the spending declines and then increases very slowly over the life course. It's pretty low at middle ages. For women, it's a bit higher in reproductive ages. There's a little bump. And then it continues to increase. And then at the oldest ages, health spending declines, probably because of small numbers of people. But generally this idea that you see, older people, the spending on older people, and this is public spending, is higher than it is for younger people, which is what you would expect, and probably why you would also expect that having more older people would lead to more spending. Now, if we look at the revenue side, so we can skip over the left, this left side, this is the spending data of how much is out of pocket, how much is from public sources, how much is from private insurance. I want to focus instead on the right side. So the right side is where the money comes from for health, for publicly financed healthcare. And these are estimates that we've done based on OECD and WHO data, but it shows you the different types of taxes that are used to finance healthcare. So in countries like Italy and Spain, where healthcare is financed through general taxation primarily for most people, you can see that the way that the overall public sector is financed mirrors the way that the health system is financed, because there's not really any earmarking, or not much earmarking, within either of those systems. As we go to the right, we see Bulgaria, Slovakia, Slovenia. All three have social health insurance systems and rely to varying degrees in red on social contributions linked to the labor market. With Slovenia, these are slightly older data. About 80% of their health insurance fund is funded through the labor market. And as we'll see in a moment, by relying a lot on social contributions, because this is paid primarily from the working age population, you would expect then that as the population ages, you'd have fewer people at working ages. As we saw in Spain, it goes from 60% to 50% over the next 20 years. You would expect then to see the ability to raise revenues would fall. Makes a lot of sense. Now, to understand this better, we have this very simple simulator tool, which you can find online. It's called the PASH simulator. If you Google it, it's on the European Observatory's website. It stands for Population Aging Financial Sustainability Gap for Health Systems Simulator. This is why we gave it an acronym, because it's a very long name. It's a very simple tool that simulates what would happen in the future if nothing changes to health financing by age. So if the way that we raise money for health stays the same, so that same reliance on social contribution, social contributions that we see here in Bulgaria, Slovakia, Slovenia, that would stay the same forever, but the number of people contributing would change. Same for health spending, that spending by age per person, I'll go back again actually. So these figures, these would stay the same forever, like weights, but the number of people would change. And so the idea of the simulator is it's meant to sort of take this obvious thought experiment of, okay, there's more older people, less working age people, we expect to raise less revenues for health, and we expect to spend more. Well, what does that actually look like? And I think it's useful. Again, it's a simulation tool. It's not a forecasting tool. It's really just taking this very simple idea and carrying it forward. And I think it's worth doing this, even though it's very easy. This is why we created this, because I think first off, it helps us to challenge this idea that aging populations, as Christina said, it's a challenge for health systems, but it's not this automatic, I think she used the word tsunami, not necessarily, right? It depends. And this way we can sort of challenge this idea by saying, okay, well, what is the actual effect of changes in the age mix of the population on health revenues and expenditures? We can also show then that financial sustainability is not only achieved by cutting spending, because most forecasting tools look only at the spending side. And obviously, if you see spending is increasing too quickly, the solution is to cut spending. Here we look at both spending and revenues. And what's nice about this also is because it's very a simple tool, you can look at different policy choices. So you can make assumptions, you can test different ideas to see, okay, well, how much would this likely impact on these trends? So you can say, for example, especially using a more sophisticated version of the tool, if we could reduce end-of-life costs, how would that save enough money to make expenditures more closely aligned with revenues? So I'm not going to go into details of the simulator, but also happy to answer questions. This is looking at the PASH for 5 countries, the same 5 countries, Slovakia, Slovenia, Spain, Bulgaria, and Italy. This is showing the size of the gap between revenues and expenditures relative to the base year of 2024 in 2060. So for example, you can see in Spain, almost all of the gap is driven by expenditures, which makes sense because there's this very diverse mix of taxes that are used to fund the health system. And because there's this diverse mix of taxes, a lot of it is based on consumption taxes, it's much more resilient to changes in the population age mix. Whereas you see in a country like Slovakia or Slovenia, a lot of the gap is because of the decline in revenues, because the working age population shrinks. Now, what we can do once we've estimated the size of this gap is we can then convert the size of this gap, even though we make an assumption that revenues and expenditures are equal to each other in the base year, we can then convert this estimate into currency. And so because we know if we index it to 100, we know that a value of 100 is the spending in the base year. And so we can estimate if we think that there's no capacity to raise additional revenues in the future and people continue to use services in the same ways, so expenditures are the same, our assumption is that the gap will be filled by out-of-pocket spending, either because countries will raise co-payments or they will ration services in other ways that will lead people to pay privately out of pocket to private providers. So what we can do is we can estimate how much more each household on average would have to spend out of pocket to fill the gap in each year. And that's what this figure here is showing. So by 2060, in orange, we have Spain. The average household would spend about 1.9 times as much out of pocket as they do now to fill the financing gap. Again, it's hard to really conceptualize what that means. So what we do is we take that data, that 1.9 multiplier or 1.88, and we apply it to the household budget survey data that we use to calculate catastrophic spending that Tamas showed. So that way we can estimate if nothing changed, and of course things change, the mix of the population changes, but if the households were the same, but they were just spending more, 1.88 times more in the case of Spain, how much would catastrophic spending increase? And so this is looking across all 5 countries for a number of years, broken down by the poorest quintile in the darkest color, the richest quintile in the lightest color. I think I'll just show this figure first. I have Bulgaria circled, but I'll explain why in a moment. But this shows you the difference in catastrophic spending just between the base year, so the most recent year of data, actual data that we have, and how much catastrophic spending would increase as a result of this multiplier, which is people spending more out of pocket to fill the financing gap. It sounds like a lot, but it's hopefully you're still with me. What you see is that in Spain, even though it's covered up by this label here, it increases from about a little less than 2% of the population of households specifically experiencing catastrophic spending to just about 5%, which is not that big of an increase. We see much bigger increases in Slovakia. Bulgaria, the increase is big, although if we go back a slide here, we can see that Bulgaria in blue at the bottom has a very small relative. The multiplier for out-of-pocket spending is quite low, but the overall effect is very high because a lot of people are still spending because, as Tamas showed as well, Bulgaria has the weakest financial protection in the EU. Most people are spending out of pocket. There aren't protective mechanisms. So even though there's a small additional expenditure required to fill the gap and it's spread across the population, since there's no protective mechanisms in place, everyone is spending, there's more catastrophic spending. And I'm going to stick with Bulgaria in a few minutes, but first I want to show you, there's obviously another side to this. So we're assuming in this first analysis that people spend out of pocket to fill the gap. But obviously there are people who, when faced with out-of-pocket spending, will decide not to use care. And so what we've done is we've done a modeling exercise, which is brand new. Just like Tamas has things that he's never presented before. I've never presented this before either. They asked the question, what if people don't use services because healthcare is too expensive? And so we try and quantify what might this be like. And so to do that, we have micro data from EU Silk for 32 countries from 2004 to 2024, which is over 5 million usable observations. And what we're doing is this is the model, which I'll explain, is we're predicting the probability of a person experiencing unmet need conditional on a bunch of covariates, a bunch of factors, one of them being out-of-pocket spending in a country and a year relative to that person's disposable income. So the idea is that if there's more of a reliance on out-of-pocket spending relative to people's income, their disposable income, that we expect then that they will, if that's the expectation that out-of-pocket spending is high, people will have a higher propensity to not use services, and it will predict higher rates of unmet need. We also control for health status, whether people have any chronic conditions, whether they have activity limitations, the size of their household. Activity status is related to employment. There's something behind that label. I don't remember what it is. I think it's urban and rural. Yes, it says Earl here, so there's probably that must be rural. Marital status, age squared to have some non-linearities, sex, and then country fixed effects and year fixed effects to control for time invariant factors and things that affect all the countries at the same time. Now, if we just look across countries, so this is each of these dots is a country and a year. On the vertical axis is unmet need in percents, so 0.05 is 5%. On the horizontal axis is the average out-of-pocket spending to disposable income. And you can see maybe not as, there's more dots than in Tamash's scatter plots, but I think that the relationship is pretty clear that the countries where there's a higher reliance on out-of-pocket spending relative to people's disposable income, you see a higher incidence of unmet need. I will say before I show the next slides that unmet need, I think, is a really terrible indicator. And that people, because it's self-reported, I think people don't always know. I think it varies a lot culturally if people are going to report unmet needs. So I think that the levels you have to take kind of with a grain of salt, as they say. But I think that the relative differences across countries make a lot of sense. So this is the results of a Probit model looking at the marginal effects for the probability of unmet need. So you can see here as the share out-of-pocket share at a country level relative to an individual level in disposable income increases, then the probability of experiencing catastrophic spending, unmet need increases, although not a huge amount, just considering how big this changes from 0% to 40%. It only increases from about 3.5% probability of unmet need to a little less than 5%. So if we do this for Spain, and as you remember, the out-of-pocket spending from the patch simulator, we assume that due to population aging, to fill the gap, we need about 1.9 times more out-of-pocket spending. So we can take that 1.88, apply it through the equation, and estimate how unmet need would change as a result of the expectations of higher out-of-pocket spending. And so the baseline average unmet need in Spain, based on actual out-of-pocket spending, is about 1.8%. And the predicted unmet need with this additional out-of-pocket spending is 2.3%, which is not a huge difference, but in relative terms is notable. It's about 130% more unmet need than in the base year. So a lot of people not using care as a result of the expectation that they will have to finance it themselves. Just to illustrate very quickly, I said I would come back to Bulgaria, and then I'm done. To understand the importance of coverage policies. So as you saw, Bulgaria was the worst performer in terms of catastrophic spender. And one of our big arguments is that it's not just the way that you raise money and spend on healthcare that determines financial sustainability and financial protection. It's also important how you design coverage policies. So what we wanted to see here is what would happen in a country like Bulgaria if they had an Austrian-style cap on copayments. So what is an Austrian-style cap? So basically, the simplified version of this is that for outpatient prescribed medicines, people can't spend more than 2% of their net annual income on medicines. At that point, it's capped. There's some other more complicated copayment rules that vary by fund, but we're keeping this very simple, and we're making an assumption that because we can't distinguish between medicine spending that is over the counter versus that's prescription, we assume here, for the sake of argument, that half of each household spending is over the counter and half is on prescriptions. So big assumption, but so this figure here shows how many households would have exceeded the Austrian-style cap in the base year and in 2060. So about half of households in Bulgaria would have gone beyond this 2% of net annual income threshold. If we look at 2060, when out-of-pocket spending is increasing because of population aging and the need to fill the financing gap through out-of-pocket payments, it increases to about 60% of the population. Now, the next question, I think this is my last slide, is well, what happens then if we apply an Austrian-style cap? So on the left here, this is the actual Bulgaria data, as we saw from Tamás as well, that about 20%, 19.2% of households experienced catastrophic spending in the most recent year of data that we have available. In 2060, if there were no cap and we just allow people to spend more out of pocket to fill the financing gap, it increases to about 26.4%. But if we had this cap, or if Bulgaria had this cap, catastrophic spending would be about 18.1%. So still very high, but lower than it is now. And the cost of filling that gap, so by replacing that additional spending that we would have seen here with this Austrian style cap, it's not that expensive. It's about 82 euros additional spending per person in 2022 prices. So about 13% more public spending per capita, which is, so I think this is my last slide. Yes, it is. So I think the message that I want to convey from this, and then I pass it on to Sarah, is that population aging can have an effect on financial sustainability, although it depends on how you raise revenues, and it depends on how you spend. But if countries are unable to improve the financial sustainability of their health systems, the costs are going to end up being shifted towards households, and that, without strong coverage policies in place, will mean more catastrophic spending and more unmet need. And I pass it on to Sarah next. So thank you.
Thank you very much. And now we invite our last speaker, Sarah Thompson. She will speak Spanish. No? Sarah will try to answer the last question, which is why coverage policy do matter. Thank you. Now I repeat or no need? Okay. Sarah is a senior health financing specialist. She leads a project looking specifically of whether people can afford to pay for healthcare. And she also coordinates the Universal Health Coverage Watch platform, which is monitoring the access to affordable care in European and Asian countries. I am very happy to have Sarah here, and she has another very interesting point in her CV, which is we did together the master in London, some about 20 years ago, more or less. More. Thank you, Sarah, for being here, and the floor is yours.
Thank you, Luisa. Is this working? It's on? Sure. I don't hear it.
But you should try to.
Oh, I see. Okay.
You should try to speak up for
It's
the people here.
feats
Or you get closer.
Can you hear me from here if I speak like this? Okay. So I need the clicker. I'm going to be talking about coverage policy and why it matters in good times when the economy is booming, but also when the economy is not doing so well, and perhaps when we have shocks to the system, longer-term shocks like population aging, or short-term shocks like economic crises. Just to remind you, when we talk about affordable access to healthcare, we really mean that there should be no financial hardship, no catastrophic health spending, which Tamás talked about, and also no unmet need for healthcare. So people should be able to use health services without experiencing financial hardship. And I just point out these different treaties or commitments that EU countries in particular have made to this idea of affordable access to healthcare, because I think the EU in particular has really intensified its focus on this in the last 10 years. And in 2021, EU member states signed up to the European Child Guarantee, which means that every child at risk of poverty or social exclusion should have totally free access to healthcare. And I want you to think about whether that's the case in Spain, or other countries that you're familiar with in Europe or not. When we think about affordable access to healthcare, the policy area that we focus on the most is this idea of coverage policy. And you all, I think, are probably familiar with this cube here. So we look at whether the whole population is covered. We look at what people are covered for. So what's in the benefits package? Does it include dental care, mental health, medicines, medical products? Are there issues with quality or waiting times for healthcare, which might push people to experience unmet need or to actually pay out of pocket in the private sector
And maybe some of those people will experience financial hardship as well. And then finally, are there co-payments, user charges, user fees, copagos for healthcare as well? It's an important coverage policy. These three dimensions are an important determinant of out-of-pocket payments in a health system. But really importantly for our discussion today, they also determine who is paying out-of-pocket payments, so the distribution of out-of-pocket payments across people. So when we think about shocks to the health system, we really want coverage policy to be resilient. And what I mean by this is that the health system, the way in which the coverage policy is designed, is prepared to meet a shock in the first place. But when the shock happens, it's also able to respond to the shock and provide people with the protection that they need. So what this means is that definitely you don't want to have any major gaps in coverage, particularly for people with low incomes, people with chronic conditions. But coverage also needs to be counter-cyclical. So as the economy is going down, incomes are falling, you want the protection that the health system provides to actually increase, to meet the increased need for healthcare and people's lack of ability to pay for healthcare because their incomes may be falling, they may be losing their jobs, and so on. At an absolute minimum, we argue that people with low incomes should not have to lose their entitlement to healthcare in an economic shock, and they probably shouldn't have to face co-payments either, because it may be very difficult for them to pay for those things. So in 2023, we published a big comparative analysis of affordable access to healthcare across around 40 countries in Europe. And we identified some of the coverage policies that we think that countries should avoid if they want to make progress to universal health coverage. If you have different objectives for your health system, then you don't need to worry about this, and we can all go home now. But if you really do want to provide good financial protection, these are the things that you should be thinking about avoiding. And I'm going to go over the first two very quickly because Spain actually does well on those first two policy areas. I'll spend more time on the third and second one, and I'm not going to discuss the fifth one now, but you can ask questions about it later if you're interested. So the first, avoid. And Spain doesn't do this. So Spain is in a good situation here compared to many other countries in Europe. But it's the idea of linking entitlement to payment of social health contributions. John showed you in his presentation how many countries in Europe have social health insurance schemes. Those are the countries in red in this chart. And often, but not always in those countries, if you don't pay your social contributions, then you don't have access to the benefits of the social health insurance scheme. And I think that you actually tried this in Spain in 2012 in the economic crisis, and you realized then that it was excluding people from coverage. So what you see in this chart here is countries on the left-hand side that cover more than 99% of the population, and Spain is up there. And countries on this side where there are really quite large gaps in population coverage, less than 99%, and in some cases, much higher than that, much larger gaps than that. And the difference between the two sides is that in this country, all of the countries link entitlement to these payment of these social health insurance contributions. And just so there's no confusion, when I say social health insurance contribution, I mean the payroll taxes, the taxes that you pay on your wages that are then earmarked for healthcare. So in those countries that have social health insurance contributions, that also have maybe a large informal economy, it's difficult to capture, to make sure that everybody's paying their contributions. The tax system is not functioning as well as it should be. You end up with these large gaps in coverage. And it really tends to affect people with low incomes, people in the informal sector, people in precarious jobs. So it's very unfair. It's also very inefficient. And it really undermines the resilience of the health system. At a time of economic shock, when people are losing their jobs or their wages are falling, some of them will decide that they cannot afford to pay the contributions and they lose their access to healthcare. It can also have an impact on financial protection, financial hardship. And you can see that the dots I've added to the chart here show the incidence of catastrophic health spending. And the median value is much higher, 3 times higher in these countries than it is on the countries on the left. But it's important to note that just being covered is not enough to guarantee financial protection, because you can see that in the countries on the left, some of these countries that cover the whole population also have very high levels of catastrophic health spending. Countries like Italy, Greece, Latvia as well. So being covered is very important for financial protection, but it's only the starting point. Spain doesn't need to worry about this because you have entitlement that's based on residence. And one of the policies that we advocate is that countries should base entitlement on residence so that everybody who's resident in a country is covered. This is a minimum. You also have a broad revenue base because the health system is largely funded through the government budget. And that means, as John showed us in the previous presentation, that when the population ages, the revenue base, the public revenue base, is pretty robust in Spain. So no changes needed there. So Spain doing well on this aspect of coverage policy. The second coverage policy that we think people should avoid is excluding people from coverage, explicitly excluding people from coverage. And the most common group of people in Europe that is explicitly excluded from coverage is undocumented migrants, so migrants without papers. And this chart just shows you the different entitlements that undocumented migrants have across EU countries. And you can see that I've marked Spain in green there because Spain is one of the few countries in which all migrants have the same entitlements as other residents. This is quite unusual, as you can see from this chart, in Europe. So again, Spain is really following our second best practice or good practice rule, which is all migrants should be entitled to the same benefits as residents, and they shouldn't face administrative barriers as well. Not only did Spain restore access for migrants in 2018, I think this year, 2026, they've also just passed a law which means that some of the administrative barriers that migrants faced in accessing their entitlements have been removed. And it should now, in theory at least, be much easier for migrants to access the healthcare to which they're entitled. So again, Spain leading the way, probably globally, actually, I would say, on this particular aspect of coverage policy. Now that was the good news for Spain. Now we come to the areas where Spain doesn't do as well as it should do, or as well as other EU countries do. So the third avoid is failing to cover treatment in primary care settings. And what is it that I actually mean here? So this chart shows you current spending on health, so all spending on health broken down by different types of healthcare, from inpatient care on the left to dental care on the right. And it shows you how these different types of healthcare are financed. In green, it's public spending on health. The yellow is through voluntary or private health insurance, and the red is through out-of-pocket payments. And what you can see here is that inpatient care and outpatient care are very highly publicly financed. It's really the government paying for most of that care. Diagnostic tests to a lesser extent, but when you come to things like medicines, outpatient medicines, medical products, so by medical products I mean hearing aids, glasses, wheelchairs, that kind of thing, and dental care, most of this care is financed through out-of-pocket payments by households. And what's interesting is that there's very little private health insurance here as well. Although it says 11% for dental care financed through private health insurance, that's the EU, the average for these 14 older member states of the European Union. And this is really heavily skewed by the Netherlands, which has a huge market for private health insurance covering dental care. In most countries, there's very little dental care insurance. So outpatient medicines, medical products, dental care, these are things that we would expect people to be using in primary care settings. But actually what the data are telling us is that there seem to be quite big gaps in coverage. There's a lot of out-of-pocket spending here. And when you look at the data for Spain underneath, you can see that for medicines, the out-of-pocket payment share is about 33% for Spain. It's the same as the EU 14 average. But when it comes to medical products, so these hearing aids, glasses, wheelchairs, and dental care, there's almost no government spending on these types of care. This is really quite shocking data from Spain. Almost all of this is financed through out-of-pocket payments. And again, very little spending through private health insurance. Most of it is really people paying out of their pocket. And you can see that this really has repercussions for affordable access to healthcare, because financial hardship, catastrophic health spending is also really heavily driven by these three different types of care. So this data shows you out-of-pocket payments in households with catastrophic health spending across countries. I've highlighted Spain with the red arrow there. And this is what they're spending their out-of-pocket payments on by type of healthcare. So in the countries with weaker financial protection, they're spending mainly on medicines. In the countries on this side with better financial protection, they're spending mainly on dental care and medical products. And in Spain, you can see there's a lot of spending on medical products. It doesn't look like there's much spending on dental care in Spain, but that's because some of the dental care products are classed under the orange category, the medical products in Spain. So these gaps in spending are really leading to gaps in really leading to financial hardship for households. And then if we focus just on the poorest fifth of households with catastrophic spending, you can see that in almost every country, it's really medicines that's driving financial hardship, outpatient medicines. And actually, in most other countries, the dental care share and the medical products share goes down in the poorest country, in the poorest quintile. But in Spain, it stays the same. In fact, increases for dental care. So dental care and medical products are also driving financial hardship for the poorest households in Spain. So our good practice recommendation for this aspect of coverage is that medicines and medical products and dental care should not be seen as some luxury that is not in the benefits package. These things should be covered, not just for children, but also for adults. And this is really a first step. In Spain, typically there's very little non-emergency entitlement to dental care for adults. There's a little bit of non-emergency dental care entitlement for children, but clearly not enough given how much out-of-pocket spending and financial hardship is linked to dental care in Spain. And I know that there's regional variation across Spain and that there are also lots of local, autonomous community, municipality schemes to provide dental care for people with low incomes, and clearly that's something that needs to increase. Just to illustrate, I know John said that he hates unmet need data. That's why I'm just showing you data for one country, so you can just compare one country over time. Even with that, there are sometimes issues, but I think we're on relatively safe territory here with Spain. So this shows you people reporting unmet need for dental care due to cost or distance or waiting time. And overall, Spain looks like it's not the worst performer in the European Union. It's just above the EU average, but it's not doing as badly as you might expect. But I just wanted to focus on the trend over time and really just to flag how it is much higher among the poorest fifth of the population than the richest fifth, as you would expect. And also that there was a big increase in unmet need in the poorest fifth of the population during the years of the economic crisis. And I just flagged this here. I don't know if there were any changes in policy or whether this was simply because people were becoming poorer and losing income and therefore their ability to pay out of pocket for dental care was affected. Probably the latter. And it just shows you how important it is in a time of economic crisis to make sure that people with low incomes do not lose their coverage and they have extra protection. That's for dental care, which is a big gap in Spain. As for medical products, which we also think is probably a big gap, we don't have any internationally comparable data on unmet need for those things at all. Okay, the last aspect of coverage policy that I'm going to focus on today. So the fourth coverage policy choice that we think countries should avoid is applying user charges or co-payments without making sure that you're protecting the people who most need protection from co-payments. So this chart shows you the presence of co-payments by type of healthcare in the EU and UK. And on that column there, you can see the different types of healthcare. And then here you see all the colorful dots depicting where there are user charges. If the dot is full, it means there's a user charge. If the dot is cut in half, it means that care is just not very well covered. And the first thing to say from this is that Spain actually does pretty well on this. You have very few co-payments. It's really for outpatient medicines, for medical products, and for dental care treatment where it's provided. But the provision of dental care is inadequate. And like many other countries, many countries try to protect primary care visits from co-payments because they know that co-payments are a barrier to access for some people, and therefore they want people to access primary care. They make primary care visits free at the point of use. But you also see that almost all countries have co-payments for outpatient medicines, for medical products, and for dental care treatment. And so although access to primary care to visits is free, the treatment that you need or obtain in primary care is subject to co-payment. So primary care is often not as free as it should be in most of these countries. And that can be an important source of financial hardship. This slide shows you, so our fourth good practice recommendation is that if you have co-payments, if you don't have them for things, then don't introduce them. If you have them already, then really think hard about the design and how you can redesign them to protect people with low incomes. So this slide shows you the incidence of catastrophic health spending, so the share of households with catastrophic spending in two broad groups. And on this side, quite high levels of catastrophic spending. These countries often have co-payments, but often in the form of percentage co-payments. So the user pays a share of the cost. They also try and protect people from co-payments, so they have mechanisms to protect people, but often they're not as effective as they should be. Whereas on this side of the chart, you have a lower level of financial hardship and much better protection from co-payments. And I'm talking here about co-payments just for outpatient medicines. The rest of this is going to focus on outpatient medicines. So the way in which you can protect people is really to start by making sure that people with low incomes don't have to pay co-payments. If you have co-payments like we saw from John in Austria, you can have a cap on co-payments. And it's really great if this cap is linked to income because then it's more protective for people with low incomes. And it's also more protective for the budget because it means that you're not wasting so much money protecting very rich people who don't need so much protection from co-payments. We also know from a lot of international evidence that it's very important to have protections that are applied automatically using digital tools if possible, so that the person who is benefiting from the protection doesn't have to fill in a form, doesn't have to apply. It just happens automatically in the pharmacy or the healthcare provider. And if you can't do any of those things, or it's very difficult for some reason, then make sure that if you have co-payments, try to avoid using percentage-based co-payments, which are very complicated, very, very complex, very untransparent. So this is what you have in Spain, when you have to pay either 40% or 50% or 10% of the cost of medicines. It can be really confusing for patients. So instead, replace them with very low fixed co-payments, like €1, €2 per medicine, so people know in advance exactly how much they're going to pay when they go to the pharmacy and don't have to worry about, will I be able to afford it? How are we doing for time?
Yeah, fine.
Okay, I just have a couple more slides. So this is just to show you that redesigning your co-payment policy to have these protections in place can really make a huge difference for financial hardship. You can see that this is the predicted probability of catastrophic health spending for an older person in the EU. And it's very, very high in countries that have percentage co-payments for outpatient medicines without any protection from co-payments. But if you have low fixed co-payments instead, and you have exemptions for people with low incomes, and you have a cap on co-payments, then the probability of catastrophic health spending really falls to around 2%. So my questions for those of you in the audience here, for Spain, for Catalonia, are really why, for medicines, you have these percentage co-payments. Why didn't you just have a fixed co-payment, 1, 2, 3 euros, instead of people paying the percentage of the cost? Why are there so few exemptions from co-payments, particularly for people with low incomes? Many countries exempt children from co-payments, so why do children have to pay for co-payments in Spain? And why is there a cap for pensioners, which is good, very good, it's linked to income also, but why is there no cap for working age people, who may also have low incomes? I know that there have been really important reforms in Spain in the last 5 years. In 2020, exemptions from co-payments were extended to people with the the minimum guaranteed income. And in 2026, this year, there's a proposal which has just been released to introduce a cap for some working age people, so people earning less than 35,000 euros. So the government is definitely moving in the right direction. But some gaps still remain. And the question is, why have user charges for medicines at all? Is it because policymakers don't trust people to use medicines wisely? Or is it that they don't trust doctors or pharmacists to prescribe and dispense medicines appropriately? And if that's the case, why are they punishing people for the mistakes, let's say, or the lack of care of prescribers and pharmacists? I'll just go through this very quickly. So we know there's a lot of evidence that shows that co-payments are not really good for reducing low-value care. They have a lot of negative impacts. They, particularly on health outcomes when it comes to medicines, they can reduce adherence to medicines. And what we're really saying is that if we have co-payments, we don't mind if richer people who are able to afford the co-payments use low-value care, but we're okay if that deters poor people, people with lower incomes, from using the care that they need. So co-payments target patients, but it's really the providers of healthcare, the suppliers of healthcare that policymakers should be targeting if they're concerned about inappropriate or low-value healthcare. And before you introduce co-payments for medicines, I think there are many other policy tools that you could think of to actually reduce or make sure that there is as little waste in the health system as possible. And most of these are targeting people on the supply side, providers, but also pharmacists, dispensers. So I will close with this coverage policy checklist for Spain. Spain doing really well on population coverage. The population coverage policies that you have in place are really making your health system resilient to shocks. There are important gaps, however, when it comes to service delivery. We talked about the gaps today in dental care and medical products. We didn't say anything about mental health care because that doesn't show up in the data we have, the household budget survey data, but I know from other data that I think that's an issue. We haven't talked about waiting times because, again, those don't really show up in the internationally comparable data we have, but probably an issue pushing people to pay out of pocket as well. On user charges, Spain doing quite well because the use of user charges is very limited, and the protection for people with low incomes is really improving and has improved a lot and will continue to improve, but there's still more to do, and maybe you could think about reducing them even further. And then just the last, I could not help myself but say that if you have private health insurance, providing people with faster access to healthcare, and you encourage that through the tax system by providing tax incentives, and private health insurance generally benefits richer people, people living in urban areas, people with higher incomes, then it's quite an unfair use of public money. It's quite an inefficient use of public money, and ultimately it could have negative implications for the performance of the rest of the health system. So one way to save money would maybe to get rid of tax incentives for private health insurance. Thank you for listening to me. I'll stop there.
Thank you very much, Sarah. You join us now. And now we open the debate. Abrimos el debate. Quien no esté a gusto preguntando en inglés puede preguntar en español o catalán y traducimos. Y preguntamos también especialmente a las personas que están conectadas. Pueden levantar la mano y abrir el micro o pueden escribir preguntas en el chat. ¿Alguna pregunta o comentario en la sala? Any questions or comments? Micro. Sí.
Hola, jo sóc d'usuaris i estic a la taula d'odontologia aquí a Catalunya. La veritat és que tenim una nova llei, però aquesta llei, de fet, com deia ella, protegeix sobretot els nens. Però a les persones adultes, nens, embarassades, la presó, però la població en general, sobretot les persones grans i sense recursos, no tenen accés, almenys des del meu coneixement, a les pròtesis que s'hi poden donar qualitat de vida per tenir més salut. Respecte d'altres països com es podria això comparar, millorar, perquè és una cosa molt preocupant. Nosaltres teníem un programa en el seu temps, que era Odontocus, que és de la nostra entitat, per donar servei amb això. Vam deixar de fer el 2018 i la cosa ha empitjorat. Gràcies.
Gracias. The question is, in Catalonia, there are new policies for improving access for children, pregnant women, and people with liberty in prison, in jail. No, in jail, no, not poor people. And the question is, what would be your recommendation to improve access to, and it is important for poor old people who don't get access to mental care, dental care. And what would be your suggestions to improve in investment in order to improve the coverage in and access to to dental care? Dental. Did you understand me? Mm-hmm. So, do you have any suggestion, please? Okay.
Oh, shall I use this one? Can I use this one? This one works.
Okay.
So you saw from the slide I showed you that there's just very, very little public spending on dental care in Spain. And that's not the case in many other countries in Europe. It probably is one of the areas where there is least public investment in terms of total spending on dental care. But there are many other countries in the EU that spend much more publicly. So I think if I understood your question correctly, that there does need to be more public spending on dental care. First of all, there has to be some. You can't just have 99% out-of-pocket payments like in Spain. And then I guess the question is how you spend that, how you get more money.
Yeah, how you spend more money into dental care.
How you spend more money. So I guess that the principle that we've set out today is that you really want to provide protection for the people who need it most. So I think that would be starting with people with low incomes. So prioritize, and I think that's what's happening in Catalonia already. So prioritizing access to healthcare for people with low incomes, so that there is some dental care coverage for them. For adults, I think in Spain there is some protection for children, but there is really very little for adults. So expanding that protection for households with low incomes, and then gradually expanding outwards from that. Anybody else?
No. En general, a Sara, no?
And sorry, just one more.
You have to speak up, or you want to stand up, if not.
I was also going to say that you just need to make sure that people are able to access the services, because in some countries dental care is covered, but we see very little spending on dental care because dental care is limited to public facilities, and there are just not enough public facilities for people, and people face either long waiting times or they just don't have access to the public facilities at all. And so I think looking at your market and making sure that it's not just that you're putting money into services, but that you're putting money into services that people can actually access is very important. So it may be, if your provision is largely private, it may be a question of giving people vouchers and just thinking, but just paying attention to this issue as well.
Sí.
Can I just add?
Un momento, ¿se oyó o no? ¿Más o menos? Bueno, ella ha dicho dos cosas bueno, hablaré lo que me salga. Ha dicho dos cosas fundamentales, ¿no? Uno, que efectivamente hay que poner el foco en las personas que no tienen los recursos, y lo segundo es que el foco tiene que tener en cuenta que no solo se trata de decir tienen acceso, sino están cubiertos, sino que además que tengan acceso a los servicios dentales, porque en este país, por ejemplo, son muy limitados. Entonces, que a lo mejor hay que pensar en involucrar también al sector privado. Claro que a mí eso me da como yuyo, pero es lo traducido. ¿Tamás?
Let me just add that in many European countries, it's not only that dental care is better covered, but it's available also in private practices. So those who are, because some countries are concerned that, okay, if we open up the market and then people can go, publicly covered, people can go to private providers, then it's going to be impossible to cover all the increases in cost. Well, I would have 2 points here. One is that Sarah already mentioned that if availability is limited to public provision, public providers, and we completely separate the two, then that's potentially an access barrier. So, many countries overcome this by making it available both at public and private providers. Second, because there is this tradition that most people use private, out-of-pocket spending for dental care, I would say there is no risk of huge increases in public spending if you cover low-income people, children, or those in universities, so those who still study or unemployed and all those, because there is a tendency that people trust the the private dentist more than the public dentist, if there is clear separation of the two. So that's why I'm saying that it's good to have both public and private providers contracted by CatSalut, let's say, and also it's not a major risk if you let some people have publicly funded services, because there will always be the richer ones who will say that, okay, I still want to go to the private provider. And with dental care, that's more likely to be the case than in other areas of health services. Definitely, the current coverage and current public spending on dental care is just unacceptably poor in Spain, especially if we compare it to other areas where you are performing so well.
¿Sí? ¿Más preguntas o comentarios? También para las personas que están conectadas, sí, por favor.
Hi, thank you. It was really interesting. Regarding to, you said mobility is a proxy for aging people. Do you have any data on physiotherapy that you're using for this type of?
Good question. No, not really. No. So the point about so this was in that second slide I think I showed with the activity limitation. So the way that there's lots of different ways to measure morbidity as people, at different ages. And I prefer this measure, healthy life years, because it's based on activity limitations, because that's a much better measure for people's their functional capacity than things like diagnoses, that you can have lots of health conditions but be totally functional. And for some conditions, if you have hypertension, it can be very inexpensive to manage the condition. So I think activity limitations are a really good metric for understanding how well people age. But in terms of access to things like physiotherapy, I don't know anything about. I don't think there's any metrics that we're aware of usually the spending data is not so granular. So no.
But let me just say, because this is for a research community, that this is an area which is absolutely under-researched, and there is potentially some interesting outcomes that you would have, or we could discuss. I believe, because there is no evidence, so all I have left is belief. I believe that we underappreciate the potential beneficial impact of having physiotherapy easily accessible, or more easily accessible, instead of waiting until it gets so serious that major operations are needed with who knows what outcome. And at the end of the day, a lot of the out-of-pocket expenditure goes to physiotherapy because it's either not accessible or not available without a long waiting period, or simply there is hesitation about their effectiveness. While at the same time, we have similar hesitation about effectiveness of some cancer care at late stages in the disease, but that's about death and life. Therefore, people are much more willing, and governments are much more willing to reduce the evidence threshold before covering those services. But physiotherapy is completely under-researched, and we don't know whether how much that is actually affecting not necessarily only the out-of-pocket expenditure, but more importantly, the health outcomes. And I think it's definitely not well covered either here. I'm currently testing Cat Salut on that, but I've been on the waiting time for 3 months now. I shouldn't have said that because it's not research, it's just one observation.
Maybe I was very surprised about the numbers you show to Ireland. Maybe because we made a trip 2 years ago, and the guide say to us that there was much more worse in Ireland than if you compare in Spain, no? Do you know which? Ireland. I was very surprised.
Which numbers?
The guy said that to us that is very, very poor there.
Which numbers were you referring?
Much worse in Ireland.
Worse, but which numbers though? The health status or the spending or the?
In general.
In general.
Maybe for the migrants, I don't know. Maybe for the
look.
European who goes there to visit and have some kind of injury. I don't know.
Was it was it the catastrophic spending one, or was it the which indicator?
It was 2 years ago. The guy maybe was from Madrid. I don't know.
Pero refieres a cuáles son los cifras que estás
¿Pero qué
hablando?
datos te parecen?
Estás hablando de
que es muy caro ir al médico allí.
Vale, por los gastos.
Sí.
Vale.
Y tienes
Sí,
que pagártelo tú.
lo que pasa es que tienen muy los pobres, la gente pobre está muy bien protegidos, y la manera de que medimos los gastos catastróficos da mucha atención a los pobres, y porque los 40% de la población tiene protección de atención primaria, de medicamentos, de todo. Son los demás que tienen que gastar por el bolsillo o que tienen cobertura privada. Pero es por eso que los que tienen más pasta tienen que pagar. Y es la diferencia, es la razón de que las diapositivas de Sarah, Irlanda tenía como una media luna para las pelotas de cobertura. Estaban como la mitad, porque los pobres tienen cobertura, pero la mitad de la población no. Sí, explica un poco.
También me ha extrañado aquí en España que se pague poco por medicamentos, cuando supongo que es debido a los que cuesta mucho dinero, los medicamentos que son muy caros, me imagino que no cubren, me imagino que es por este dato. Y también la falta, otro aspecto, ¿no? La falta de cobertura a los residentes mayores que tienen que ir a una residencia y tienen que esperarse mucho tiempo para que les concedan.
Sí,
aquí.
eso no aparece en los datos de gastos del bolsillo, claro, porque si la gente no puede hacer, es la razón de que a mí no me gustan los datos de unmet need, porque creo que mucha gente no prefieren que no dicen que tienen una necesidad que no pueden hacer.
Un momentito. Okay. Thomas, did you follow?
Thomas is fluent. He's just.
I understand what he says.
Okay.
No, I was asking that if in your analysis, did you consider the social, the expenditure on social expenses on social services? Because in your projection, in social for
No.
no,
Because
only the.
you know the reason is it's a good question, and it's a topic that we are starting to work on more. The problem is across countries, the public spending on long-term care or social care is pretty good in most countries, but the out-of-pocket spending is terrible. So you can see in some countries it looks like almost all of the spending is public. It's not true. It's just that you don't either people, because a lot of the out-of-pocket spending data come from household budget surveys. If you have dementia or you're not filling out a household budget survey. And so it's very difficult to include that in these types of analyses. But it's something that we are working on trying to understand better where these coverage gaps are, to maybe not to quantify how much spending is on social care out of pocket, but to get a better sense of people's exposure or susceptibility to out-of-pocket spending for social care.
I maybe would like to go back to the comment because porque dijiste que te llamó la atención que había muy poco copago al medicamento, pero todos los copagos están ahí, medicamentos y gastos. He said he was surprised that out-of-pocket payment for medicines was very low, but in Spain, eso es lo que dijiste, ¿no?
Al micrófono.
No son del todo buenos, como el tema de dental, tampoco nos sale bien parada España.
Sale mal.
Sale muy mal.
Sí, medicamento, prótesis y dental care. Mira qué pesada con lo de mental care. Poco dental.
Pero cuando parece que los medicamentos normales que son baratos, parece que sí que más o menos va pagando más o menos, ¿no? Pero debe ser debido a los medicamentos realmente caros, ¿no? Cáncer, no sé, yo no entiendo tampoco mucho.
Pero tampoco los gastos del bolsillo son muy altos para esos tampoco, ¿no? Es que hay un límite.
Hay un cap, sí.
Sí, hay un umbral.
Okay. Más preguntas. Esteban. Micro, please.
No, what exactly includes the term medical products in your presentation, Samson? What is exactly what is included in the medical products?
So,
prostheses, hearings, muletas, prótesis,
Uyerras.
Pero medicamentos.
Yeah,
but medicines no,
That's separate. No.
Es que creo que hay un poco ahí de confusión con el tema de medical products.
No, ve que no. Es que había mucha.
No, pero me lo han contestado, no. My question was, what was included in this group of medical products that you use in your presentation and in what Spain is not well performing? So I understand by this colleague that these are earrings, prostheses.
Yes, so prostheses, hearing aids, glasses, wheelchairs. And in Spain, it also includes a lot of dental medical products. So dentures are included as medical products in Spain.
No, the difference here in Spain compared to other countries is that here the Spanish data includes some of the otherwise dental care type of products like dentures and I don't know the list, but the difference here, and that's why you see more products for Spain compared to other relevant countries, is simply because you classify some of the dental care related products under medical products and not under dental care.
More questions or comments? Ingrid?
For Thomas, in your presentation, you mentioned about the methodological change for calculating the catastrophic expenses. Could you explain a bit in what consist these changes?
I can, but I think I should leave it to John because he claims that this is John's methodology. But my preference is that Sarah explains it because she is, no? Okay. So I'll explain then, and
then they can complement.
And then they can tell you whether I got it right. So the previous methodology just simply took household expenditure, total expenditure, and if more than 10% or more than 25%, there were two thresholds in the SDG metrics. If a household spends more than 10% of their total income or total expenditure on health, that was considered catastrophic. Now, you're researchers, so for a poor household, 10%, for a rich household, 10% are very different numbers. And what we changed is that we calculate a number, a spending level that is needed to cover basic needs: food, housing, paying for rent, and paying your bills, electricity and heating. And these three are the input to our calculation. We deduct a standard amount for each household income or total expenditure, depending on what data we have, this amount that is needed for basic needs. And what is left afterwards, that's what we call capacity to pay for other needs like healthcare. And if a household spends more than 40% of this capacity to pay, then that's what we consider catastrophic expenditure. I think what's important is that with the two different methodologies, the distribution of who are affected is very different. So for the 10% of total spending, we counted globally more of the rich people suffering catastrophic expenditure than the poor people. And with our methodology, it's very much skewed towards the poorest 20% of the population, as my third chart showed. The dark blue bars were much higher. The incidence in the lower quintile is much higher than on average, or of course in the richer quintile. So our methodology is much more sensitive to equity and what actually really matters. If in a poor country where the 80% or 90% of the population is poor, then the 10% methodology of total expenditure actually is fine because there is no huge variation across the population. And that's why in the past this lasted for so long because the World Bank is more focused on the low-income countries. And there also the problem is that our methodology requires better data and more details actually than what's easily available in Africa and other countries. But for Europe, this was essential. Otherwise, we are completely irrelevant with the old methodology for a country like Spain.
Yeah.
Okay.
No, well, I would just, I agree. I think that the old method, this 10% or 25%, is mostly because it's easier to calculate. It's just two numbers. And our method or the new SDG method, you have to agree on what the constant value is that you're subtracting from the denominator. So it's in the SDGs, in the old SDG version, it was out-of-pocket spending over consumption or income. Now it's out-of-pocket spending over consumption minus something. And for us, that something is food, housing, utilities, the cost of basic needs, which we estimate ourselves for as like a normative amount, like what should need to be spent, not what households actually spend. But in the SDGs, they use the societal poverty line, which is calculated in a different way, but captures a similar idea. And as Tomasz was saying, the outcome of this is that if you were to think about the whole population as being distributed, like the poor to the rich, I'm trying to do it backwards so that it looks to you. The poor to the rich, each household, like based on like the poorest are over here, the richest are over here, and you put all of them in a row, and then the threshold is 10%. As Tomasz said, 10% for the poor is very different than 10% for the rich. What ours does is, instead of having that flat threshold as a share of budget, it rises with wealth. So for the poor, the threshold as a share of budget is very low, and for the rich, it's very high. So we count fewer rich people and more poor people. Similar.
Thank you. And yes, micro.
Okay, I have a question about epistemology. You know, health is thought mainly as a biological and not a social. So my question is more about imagination and the future. So what would you like management and researchers data to provide you to still making tools for helping countries to make right decisions to cover for vulnerable people? Which type of data? My belief is related more to social than quantity data. I linked it to epistemology because we don't do so much quality research in quantitative research in health, and we don't have so much social sciences coming in the scene. So that's my hypothesis. I don't know if my question was clear.
I leave it to the researchers.
I mean, just one quick response on that is that when we do have data, we really want to have disaggregated data that disaggregates by income, but also by other factors that we think are important for affecting use of healthcare and so on. So I think the health spending data that we use generally are not disaggregated, sometimes by age actually, but not by income. So that's why we use the household budget survey data, because that allows us to disaggregate by income. So I think being able to disaggregate so that we're not relying on averages is really, really important, because the averages don't really matter. It's really what's happening at the bottom end that is most important. But yeah, I mean, I won't say more, just to say that qualitative research also is very important, because that, the numbers are the beginning of the picture. They indicate something, but often you do sometimes need more quantitative data, but also qualitative data to really understand the reasons why people are doing things or not.
More questions? No tenemos ninguna pregunta de las personas conectadas. I think the data you presented are tremendously powerful. So what do you do to make policymakers to make the right decision? For instance, not to give a tax incentive for private insurance, your last suggestion, or how we have a very good, I always say that, a very good national health system, but it's not perfect. There are things which are, or services or which are not covered. And how do we do to, now with this discussion about putting money for defense and not cutting public budget? So what should you and we do to make policymakers to make the right decisions? Some suggestions?
I'll start and then my colleagues continue. So I think this is a very important question, because it's not only about what and how, what the evidence is and what we present, but also how we present. And maybe, I think researchers are always disappointed by the policy impact of the research. So one suggestion is let's be a little bit less ambitious. Second, it matters how much they can actually digest. So that's why we came up with a long list of a checklist which has about 20 items of how to improve financial protection with better coverage policies, in addition to what we all know, that more public spending helps, and keeping out-of-pocket expenditure below 15% and all these things. But then we came up with 5, don't do this. These are the 5 don't do policies. And that approach works. Yeah. Because 5 is something they can cope with, and usually the 5 includes some of the absolutely silly things. So it's you don't have to present a lot of data to convince them. But once they are with you and you can discuss and talk, then that's how you release the more complex messages. And I think I just wanted to share this with you, because probably you all know this. It's just that we can confirm that this is right, this is correct, this reflects our experience working in, I think, overall more than 20 countries in the past 15 years with ministers, and of course in some cases and at some point in time we didn't succeed. So we just concluded, okay, we will have to wait for the next minister because this didn't work. The luxury in WHO we have is that we have several countries to deal with. So if we don't succeed in Ireland, then we can move on to another country. Or for Cyprus, I mean, look, Cyprus, all of us have been at some point involved in Cyprus for the past 20 years. It was completely unsuccessful. And then suddenly last few years, it worked. So it does matter also who we talk to. But I think the bottom line is that we have to just make things simpler and clearer and easier to follow, and also very blunt when it comes to bad policies like tax subsidy for private insurance, because that practically just means supporting the rich at the expense of the poor.
Thought that was good.
Oh, thank you. With John's approval.
Just to say on the private health insurance and the tax incentives, I mean, this is, you have important issues here with the organization of Mufate, which I know is different from private health insurance, but also private health insurance. And these things are very politically contentious, very politically sensitive. So sometimes it helps for outsiders to come and be able to say these things. So John and I were in Ireland a month ago, actually, and we were discussing private health insurance, and we were saying that they should get rid of the tax incentives for private health insurance. And it was just very, for the Irish audience, it was very refreshing to hear somebody say this, because policymakers have just not been able to say this in the last 10, 15 years in Ireland. I don't know if it will change anything, but outsiders can play a role. I also remember being with Tamas in Bulgaria maybe 15 years ago, when the Bulgarians wanted to massively increase private health insurance, and we had just finished a big study on private health insurance across Europe, and I was presenting the results and telling them, don't do this. And it was a meeting for parliamentarians, actually, and one of the parliamentarians stood up and said, if Sarah Thompson were Bulgarian, she would be escorted from the room. We would ask her to leave the room because of what she said. But because she's a guest and a foreigner, she is allowed to say what she says. So sometimes the outsider can say things that can't be said domestically.
Perfect. Okay. If there are no more questions or comments, no, nothing here. So thank you very much. It was very interesting. I hope to have you over some more times in the near future, not in 3 years' time, maybe. Thank you for everything. I think it was very interesting and very grateful for having you here.
Thank you, Lisa.
Thank you for the invitation, and thanks for the good questions.